Good morning, Mom. For this PowerPoint presentation, I will be the one continuing the report of me and my partner, Anissa Idris. And since my partner has already finished the first assessment of the psychological assessment, I will now continue the rest. Alfred Binet, a French psychologist, originally constructed tests to help a school board predict which children were in need of special schooling. Intelligence testing has since developed into one of the largest psychological industries. Now, intelligence test is often referred to as an IQ test, an IQ, the intelligence quotient. This test is a way of assessing a person's current mental ability. IQ tests are based on the assumptions that a detailed sample of a person's current intellectual functioning can predict how well he or she will perform in school. But beyond predicting the school performance, intelligence tests are also used in other ways, like in conjunction with the achievement test, we diagnose learning disorders and identify the strengths and weaknesses for academic planning. We can see what part of subjects that they are good at and what part of the subjects are still in need of improving, and to also determine whether a person could develop an intellectual development disorder that was formerly known as mental retardation, and to identify who are gifted enough to be given an appropriate instruction that can be provided to them if they ever get accepted in school. Like, for example, if a school can identify a gifted child, they might have to give him an acceleration approach, which could give him or her a chance to skip school 3 levels at the level where he is supposed to be based on his or her IQ. And psychological assessment or intelligence test is the most important neuropsychological evaluations, since we have so many procedures in diagnosing a patient, whether he is smart or whether he is diagnosed with a learning disorder. But what are the ways in computing an IQ test? I will give you an example in the next slide. Over here, in this example, we have the Stanford Binet Intelligence Test, or Intelligence Scale if you would rather, and it is still being used till this day. On the left side is the IQ scores, and on the right side is the description of what you are being described as based on the IQ scores. This intelligence test has been used to diagnose intellectual deficiencies among young children to the age of 23-year-old adult. This test can measure 5 factors and can consist nonverbal and verbal subsets in this test. And the average score is 160. If a person scores 40 below, then he or she might be diagnosed for mental retardation. In short, mental retardation is a disorder that a person has the limitations in their own intellectual function. And next, we have the Wechsler test. The examples of Wechsler tests are given below. the WISE, WISC, and WPPSI, or you might know them as the Wechsler Adult Intelligence Scale, the Wechsler Intelligence Scale for Children, and the Wechsler Preschool and Primary Scale of Intelligence. Both Wechsler test and Stanford Binet test are the most commonly used of standardized tests in diagnosing someone. And on the image there is one of the uh, one of the items that is being used in the Wechsler test. If you can see the small blocks there, you have to form a shape based on the instructions that is given to you. You can try to connect the blocks and make a shape of an oblong uh, or a trigon. Now, IQ tests are highly reliable and have a good criterion validity. For example, they can even distinguish between someone who are intellectually gifted and those with intellectual development disorder, and between with different occupations or educational attainment. But sometimes IQ tests have their own flaws in measuring an intellectual of a person. Because in the IQ test, psychologists only measures on what they consider that is intelligent. Factors other than what we think of as intelligence, however, also play an important role in how people will do in school, such as family and circumstances, motivation to do well, expectations, performance anxiety, and difficulty of the curriculum. Another factor relevant to IQ test is called stereotype threat. And that stereotype threat, it's suggested that the social stigma of poor intellectual performance borne by some groups. And it wasn't aware that the stereotype threat was actually developed early. For example, a study revealed that children developed awareness of stereotypes regarding ethnicity and ability. This awareness seems to influence stereotype threat and performance. And in the study of McCone and Weinstein, children were asked to complete a puzzle task rather. Half of the children received instructions that the task reflected their ability, and half of the children received instructions that the test did not reflect their ability. African American children were aware of the stereotype about ethnicity and ability showed evidence of stereotype threat. And specifically, they performed more poorly on tasks than the children who did not, suggesting that the instructions activated the stereotype and thus influenced their performance. And for my opinion, that is why EQ should be considered as important assessment. EQ, the emotional quotient. EQ is referred to as the ability to understand your own emotions and other people's emotions. IQ only measures your academic abilities. And if you combine both IQ and EQ, you would have a clear understanding of why a person is like that. Now, another assessment of psychological assessment is called the behavioral and cognitive assessment. Now, what is it about? It is the hope that understanding these aspects of cognition and behavior will guide us as being a clinicians, hopefully, toward more effective intervention targets. The aim is that we might understand the aspects of the environment that might contribute to their symptoms. For example, students might feel depressed because everyone around him does not like him, and that might contribute him to being depressed. Next is the characteristics of a person. Example, a client's fatigue may be caused in part by a cognitive tendency towards self deprecation and manifested in such statements as, I never do anything right. So, what is the point in trying? Maybe there is a way for us to motivate them. The frequency and form of problematic behaviors. Now, I know some of us students love doing this before. Procrastination, taking the form of missing important deadlines. I have faced that so many times in my life. I tried so hard not to do it again, but it's as if the history repeats itself for me and probably for the others. A direct observation of behavior is the first thing to do if you're going to apply behavioral and cognitive assessments. Now, do not underestimate if you think that this is the most easiest part. A formal psychologist or clinicians would observe a behavior of their patients time after time after time. It takes time and place to get the results that you wanted. And I don't want to mention this word, but if your calculations or your observation is wrong, then you might experience something that you have learned in the experimental psychology, an error for your data gathering. And now we have the second assessment of the behavioral and cognitive assessment, which is called self-observation. Self-monitoring, also known as, is used to collect a wide variety of data of interest to both clinicians and researchers, including moods, stressful experience, and coping behaviors and thoughts. Another method of self-observation is called ecological momentary assessment, or EMA. It involves the collection of data in real time, as opposed to the more usual methods of having people reflect back over some time period and report on recently experienced thoughts, moods, and their disorders. The method for implementing EMA range from having people complete diaries at specific time during a day. But there were issues that were given about EMA before. For example, current theories of both anxiety disorders and depression propose that emotional reactions to life event are triggered in part by thoughts that the event elicits. It is unlikely, however, that these thoughts can be recalled accurately in retrospect. So sometimes it could be false and sometimes it could be true. For example, there was a case of a man with severe attacks of anxiety. In his clinical interviews, the patient reported that his life was going very well and that he loved his family and that his work was both financially and personally rewarding. No cause of the anxiety attacks could be discerned or found what caused the attacks. And why is that? Here's more. The man was asked to record his thoughts as he went about his daily routine. Surprisingly, about a third of his thoughts were concerned with annoyance with his children. So it turns out that he is not having any cause of anxiety attacks, but it turns out that he was only annoyed by his by the behavior of his children, and He believed that anger at his children was sinful and felt unfit as a father for having such thoughts and feelings. And after that event, he entered into a therapy that focuses on the normality of being annoyed by one's children and on the important distinction between being annoyed and acting out aggressively. Almost immediately, his anxiety attacks has now disappeared. But for some research, Emma can provide accurate measurement of such behavior. Considerable research indicates that behavior may be altered by the very fact that it is being self monitored. The phenomenon wherein behavior changes because it is being observed is called reactivity. In general, desirable behavior, such as engaging in social conversation, often increases in frequency when it is self monitored, whereas behavior the person wishes to reduce, such as cigarette smoking, diminishes. So, in the end, self monitoring generally leads to increase in desirable behaviors and decrease in undesirable ones of a patient. And now we have the cognitive style questionnaires. These questionnaires tend to be used to help plan targets for treatments as well as to determine whether clinical interventions are helping to change overly negative thought patterns. Here, in this picture on your left side, is called the Dysfunctional Attitude Scale. It was once developed based on Beck's theory. The DAS contains items such as people will probably think less of me if I make a mistake. And these kinds of questionnaires tend to support the researchers when constructing validity and have shown that they can differentiate between depressed and non depressed people on the basis of their scores. And in this questionnaire, we measured our patients' achievements, diplomacy, and their own self centered based on their personality. But generally speaking, we need to see what aspects of a person can make him feel dysfunctional, because dysfunctional could mean anything, and dysfunctional could happen to anyone. So now we have reached the section called the neurobiological assessment. Now, we will be looking at the four areas in particular. For example, the brain imaging, neurotransmitter assessment, neuropsychological assessment, and psychophysiological assessment. Let us start with the brain imaging, because many behavioral problems can be brought on by brain dysfunction. Neurological tests, such as checking the reflexes, examining the retina for any indication of blood vessel damage, and evaluating motor condition and perception. If I could also add, these devices can be availed for clinicians and researchers to have much more direct look at both the structure and function of the brain. Computerized tomography, also known as CAT scan, is a type of structural neuroimaging. It involves taking a series of X-ray images from various locations around the head. These images can then be combined to construct an image of the brain. The resolutions of CAT scan images is not that high, but they can visualize any major structural problems. For example, in this picture, on the left side is the normal brain, but on the right side if you can see the yellow circle, it detects a tumor on the left side of its brain. Magnetic resonance imaging, or MRI, involves applying a combination of magnetic fields and radiofrequency energy waves to the brain. Hydrogen atoms respond to the magnetic fields and radiofrequency pulses by emitting energy. The MRI machine receives this energy and can tell what part of the brain it came from. A computer can use that information to reconstruct an image of the brain with high spatial resolution. Up next, we have the positron emission tomography, or PET scanning, is a way of imaging brain function. But to do a PET scan, a patient is injected with a radioactive substance that emits positrons, which then emit gamma rays when they collide with electrons in brain tissue. These gamma rays are detected by the PET scanner. Because the radioactive substance was injected into the bloodstream, what the PET scanner is detecting is the movement of the blood throughout the brain. Blood flow to an area of the brain increases when the area is active. So, PET scanning creates an image that highlights the areas of the brain that are being used the most while the person is in the scanner. If you can see the red colors around the brain, those are the positrons. Last but not the least, functional MRI, or fMRI. It uses a similar approach to MRI, but focuses on the different responses oxygenated and unoxygenated blood make to magnetic fields and radiofrequency energy. It can be used as what is called blood oxygen level dependent contrast, or BOLD, to identify changes in the blood flow within in the brain, and thus to identify areas of the brain that are most active. fMRI allows one to image brain function without having to inject anything, and it provides high-resolution MRI images at the same time as it provides a functional image. Another area that we need to discuss is the neurotransmitter assessment. It includes post-mortem analysis of neurotransmitters and receptors, assays of metabolites of neurotransmitters, and PET scans of receptors. Now, as you all know, post-mortem analysis is the study of those who are dead. Now, the brains of the diseased patients are removed, and the amount of specific neurotransmitters in particular brain areas can then be directly measured. Different brain areas can be infused with substance that bind to receptors, and the amount of binding can then be quantified, which means that more binding indicates more receptors in the brain. But studies have shown for the patients that are still alive, the one common method of neurotransmitter assessment involves analyzing the metabolites of neurotransmitters that have been broken down by enzymes. Now, a metabolite is typically an acid. It is produced when a neurotransmitter is deactivated. These byproducts of the breakdown of neurotransmitters such as norepinephrine, dopamine, and serotonin are found in urine blood serum and cerebrospinal fluid, in short, CSF. but it shows that measures of neurotransmitter metabolites rather, in blood or urine levels do not provide a very accurate index of a neurotransmitter levels in the brain. Why is that? Because such measures are not direct reflections of levels of neurotransmitters in the brain. Because metabolites are measured in this way could reflect neurotransmitters anywhere in the body. A more specific measure can be taken of metabolites in the CSF fluid drawn from a person's spinal cord. Even with the CSF fluid, however, metabolites reflect activity throughout the brain and spinal cord rather than regions that are directly involved in psychopathology. The next part is we are going to tackle about neuropsychological assessment. Neuropsychological tests are often used in conjunction with the brain imaging techniques just described, both to detect brain dysfunction and to help pinpoint specific areas of behavior that are impacted by the problems in the brain. Now, who can facilitate these kinds of tests? The neuropsychologist can. A neuropsychologist is a psychologist who studies how dysfunctions of the brain affect the way we think, feel, and behave. Example, we have the Halstead-Rayton neuropsychological test battery. Now, Rayton's modification of a battery or a group of tests previously developed by Halstead. Now, what are the examples? Of course, it is shown below. First, we have the tactile performance test time. Here, when a patient is blindfolded, that patient must try to fit various shaped blocks into spaces of a form board, first using the preferred hand, then the other, and finally both, which at times, if you look at the picture, at first he must form each shapes with one hand, then the next he would use his right hand, then after that he can use both of his hands to form shapes in the form board. Another is the tactile performance test memory. Now, after completing the time test, he must now draw shapes from memory. And remember, showing the blocks in their proper location, it must be that way. But it is shown that both this kind of test and the time test are very sensitive to damage in the right parietal lobe. The third part is the speech sounds perception test. Now, at this test, a neuropsychologist would give out a series of nonsense words. Each word that the participants must hear must comprise two consonants with a long E sound in the middle. They then select the word they heard from a set of alternatives. Now, this test measures the functions of our left hemisphere, especially the temporal and parietal areas. Now that we have finished the Halstead-Rayton neuropsychological test battery, let's move on to the Luria, Nebraska battery. This battery test is based on the works of a Russian psychologist, Alexander Luria. Is also widely used from every part of the neuropsychological test. This battery includes 269 items divided into 11 sections to determine basic and complex motor skills, rhythm and pitch abilities, tactile and kinesthetic skills, verbal and spatial skills, receptive speech ability, expressive speech ability, writing, reading, arithmetic, skills, memory, and lastly, intellectual processes. And with these kinds of battery test, we might be able to reveal the potential threat that is caused to damage to the frontal, temporal, sensorimotor, or parietal occipital area of the right or the left hemisphere. Now, last but not the least among the assessment of neurological assessment is the psychophysiological assessment. If you can recall the brain imaging methods that we have already discussed, the assessment we described here are not sensitive enough to be used for diagnosis, but, however, provide important information about a person's reactivity and can also be used to compare individuals. For example, in using exposure to treat a patient with an anxiety disorder, it would be useful to know the extent to which patient shows physiological activity when exposed to the stimuli that create anxiety. The stimuli, an act that can stimulate our reaction. In this part of assessment, we assessed by electrical and chemical measurements to understand the aspects of emotion. One important measure is heart rate. Each heartbeat generates electrical changes which can be recorded by electrodes placed on the chest that convey signals to an electrocardiograph. For example, in the electrocardiogram, they are waves that are being shown on a computer screen or on a roll of graph paper. You know, the ones that make lines. Secondly, we have the electrodermal responding or skin conductance. Now, we measure anxiety, fear, anger, and other emotions that can increase activity in our sympathetic nervous system, which then boasts sweat glands activity. Increased sweat gland activity increases the electrical conductance of the skin, and the conductance is typically measured by determining the current that flows through the skin as a small voltage is passed between the two increase. The two increase of the sweat gland activity and the conductance in the skin. Now, electroencephalogram is a brain activity that can be measured. How? Electrodes are placed on the scalp, record electrical activity in the underlying brain area, one of those small buttons that they first put saliva in it to stick it rather. They search abnormal patterns of electrical activity that can indicate seizure activity in the brain or help in locating brain lesions or tumor. And also, EEG indices are also used to measure attention and alertness. Now, there is a cautionary note about doing a neurobiological assessment. It is stated as inasmuch as psychophysiology and brain imaging employ highly sophisticated electronic machinery, and many psychologists as possible researchers and clinicians sometimes believe uncritically in these apparently objective assessment device without appreciating their real limitations and complications. Now, why did it say like that? Because not everyone is comfortable in doing these kinds of assessment if they want to be diagnosed with what kind of ailments or illness that they could possibly have that is found in their brain. Remember, though in my opinion, brain imaging can give you a specific detail of what a person has, it does not manipulate the emotions of your patients. Remember, we have we always have limitations in what we can do to assess our patients. Before I end this PowerPoint presentation of our report on diagnosis and assessment along with my partner Idris, there is a matter of subject that needed to be discussed in during assessment, which is the cultural bias. It is an issue that is referred to the notion that a measure developed for one or ethnic group may not be equally reliable and valid with a different cultural or ethnic group. Why do you think it is like that? Because not everyone around the world would have the same opinion when it comes to psychology and their beliefs. Everyone still believes that religion is still the answer, and it is God's decision if He would let you live or die. And also, if you could recall the WACE intelligence test, there is already a Spanish language version of that intelligence test for over 40 years and can be useful in assessing the intellectual function of people from Hispanic or Latino cultures. And additionally, MMPI-2 has been translated into more than dozens of languages. However, it does not ensure that meanings of those words will be the same across different cultures. There are many steps when it comes to translation process, including working with multiple translators, back translating, and testing with multiple native speakers that would assure that the test is similar in different languages. This approach, however, has been successful in achieving equivalence across different cultures and ethnic groups for some instruments. However, there are cultural differences that are not likely attributable to differences to psychopathology. I'll give you an example. African Americans who are not heavily assimilated into American culture scores on most MMP1-2 scales are higher than those of Caucasian. This is unlikely to reflect truly highly emotional disturbances among the Asians. For children, the latest version of WISC has not been translated into Spanish either. It also has a complete set of norms for Spanish speaking children in the United States, and the items have been designed explicitly to minimize cultural bias. They are trying so hard to try and minimize bias year after year. And not just getting a bias from ethnic groups, we also tend to be biased as well. For example, clinicians who encounter clients claiming to be surrounded by spirits might view this belief as a sign of schizophrenia. Yet, in the culture of those Puerto Rican, such belief is common. Therefore, believing that one is surrounded by spirits should probably not be taken as a sign of schizophrenia in their place. Cultural and ethnic differences in psychopathology must be examined more closely. And unfortunately, the cultural and ethnic biases can somehow uh, enter itself into any clinical assessment that do not necessarily yield to efforts to compensate for them. There is no simple answer, sadly. But there are strategies for avoiding cultural bias in assessment. Number one, must learn about basic issues in assessment, which means that whatever issues that is going, whether it is just small problem or a huge problem, it needs to be fixed right away. And we must become informed about the specific ways in terms on how we diagnose with our patients. So, for example, if you want to be a clinician or a psychologist and you want to travel around the world, you must practice and research more about their culture so that you won't be able to be perceived as someone who does not understand their culture. Either way, you must be understandable and must taken into account and what people have their beliefs. As Lopez stated, the distance between cultural responsiveness and cultural stereotyping can be short. To minimize such problems like this, clinicians are encouraged to be particularly tentative about drawing conclusions regarding patients from different cultures and ethnic background, which means that it's okay for them to draw a line, but it is not okay to draw a conclusion immediately, since they must also observe and understand where they come from before they make a conclusion. And that concludes my part on reporting Chapter 3 Diagnosis and Assessment along with my partner Anissa Idris. And now I will give my summary of our report. The psychological assessments that we have discussed earlier, it shows that it can draw on many different methods and tests. Interviews can be structured with questions that are predetermined and follow in a certain order, or unconstructed to follow more closely what the client tells the interviewer. Structured interviews are more reliable. Rapport is important to establish regarding of the type of interview. And next, stress is best assessed via a semi-structured interview that captures the importance of any given life events in the context of a person's life circumstance. As in the LEDS, self-report checklists are also used to assess stress, but they have poorer reliability and validity than the LEDS. And next, the MMP-1-2 is a standardized and objective personality inventory. The test has a good reliability and validity and is widely used. Projective personality like Rorschach or TAT, Rorschach like the ink blots that you know, are not as widely used today, likely due to their poor validity. Reliability can be achieved using scoring systems such as Exner's intelligence tests have been used for a number of years and are quite reliable. Like any test, there are limits to what an IQ test can tell a clinician or researcher. As if you could remember what I've mentioned before, IQ can be important, but EQ should also be taken into consideration as well. The next, direct observation of behavior can be very useful in assessment, though it can take more time than a self-report inventory. Other behavioral and cognitive methods include Ecological momentary assessment. Remember, in direct observation, it takes more time than any of the psychological assessment methods, since it applies you to gain more information and to see the change in their behaviors by yourself as a researcher and an observer. Now take note, in gathering diagnosis and assessment information, clinicians and researchers must be concerned with both reliability and validity. Reliability refers to whether the measurements that they have measured are either consistent and replicable. Validity to whether assessments are tapping into what they are meant to measure. Assessment procedures vary greatly in their reliability and validity. Certain diagnostic categories are more reliable than others, such as psychological assessment, neurobiological assessment, or even the personality assessment, etc., etc. And diagnosis is the process of assessing whether a person meets the criteria for a mental disorder, like the DSM-5, which we are now following, or as we know it by the Diagnostic and Statistical Manual of Mental Disorders. It was published by the American Psychiatric Association in an official diagnostic system widely used by mental health professionals. The last edition of the manual, referred to as DSM-4TR, was published in 2000, and the publication of DSM-5 is expected in 2013. The DSM-5 also includes reliability, since it can improve dramatically by including specific criteria for each diagnosis rather. But some critics of the DSM argue against diagnosis in general. They have pointed out that diagnostic classification may ignore important informations, meaning that sometimes the mental health professionals might get it wrong. And that's how a stigma was created. Clinicians would rely on several modes of psychological and neurobiological assessment in trying to find out how to describe an individual, whether it is to search for the results the person is troubled for, arrive at an accurate diagnosis, and design effective treatments for them. Psychological assessments include clinical interview, assessment stress, psychological tests, and behavioral and cognitive assessment. Psychological tests are standardized procedures designed to assess personality or measure their performance. Personality assessments can range from empirically derived self-report questionnaires such as the Minnesota Multiphasic Personality Inventory to projective tests in which the patient interprets an ambiguous stimuli such as the Rorschach test. Behavioral cognitive assessment is concerned with how people act, feel, and think in particular situations. Approaches include direct observation of behavior, interviews, and self-report measures that are situational in their focus. Neurobiological assessment includes the brain imaging techniques such as fMRI, MRI, PET scan, and CAT scan. There are also neuropsychological tests such as the Luria Nebraska Battery that seek to identify brain defects based on variations in response to psychological tests. And psychophysiological measurements such as heart rate and electrodermal responding that are associated with certain psychological events or characteristics. And lastly, cultural and ethnic factors play a role in clinical assessment. Assessment technique developed on the basis of research with Caucasian populations may be inaccurate when used with clients of differing ethnic or cultural backgrounds, which means that we must not only focus one type of ethnic groups, we must also consider almost everyone around the world. Clinicians can have biases as well when evaluating ethnic minority patients, which can lead to minimizing or exaggerating a patient's psychopathology. Clinicians must use various methods to guard against the negative effects of cultural biases in assessment. And here are the reference. Please feel free to press pause and look each of it in order to gain more knowledge where the resource can come from. Resources that created this presentation. And that concludes the report on Chapter 3, Diagnosis and Assessment, reported not only by me, but also with my partner, Anissa Edris. Thank you for listening.